Good evening, and thank you all for joining us. Welcome to our fourth Community Wellness Roundtable. For videos to the previous discussions on morbidity and mortality disparity in COVID infections, long COVID, and the psychosocial impact of COVID, we have a playlist on our RCMI YouTube page, and we'll forward the link so you can view those conversations. As well, if there is a topic that you would like to see featured in our series, please let us know. Tonight, we're talking about what COVID did to our personal and household finances and how it might continue to impact our pockets. If you have questions, please place them in the chat so that we can address them in turn. Again, welcome, and we will be started in a moment. This roundtable is being recorded for later posting. Before we proceed with tonight's roundtable, we're going to take this time to hold space for the communities in Buffalo, New York, and Uvalde, Texas, that are suffering right now due to the senseless and unspeakable acts of mass gun violence. We hold space for the victims, their grieving loved ones, and those who grieve anew as they have had their lives similarly upended by an attack on an innocent loved one. We at Howard University are also taking action. Under the leadership of our president, Dr. Wayne Frederick, we are galvanizing a gun violence prevention task force comprised of our students, our faculty, and our staff to develop recommendations and proposals that we will deliver to policymakers. We ask you to consider what we might place forward. Let us know in the chat, and we will update you on this as well in upcoming announcements. So please be sure to sign on to our contact list. And now we will proceed with our programming. I'm Karen Parker. Good evening again. And I'm the project coordinator for community engagement of the RCMI program at Howard University College of Medicine. RCMI, for those who do not know, stands for Research Centers and Minority Institutions. And I'm joined by my colleague, Ashley, who is co-hosting with me.
Thank you, Karen, and good evening, everyone. As she said, my name is Ashley Goodwin, and I'm the administrative coordinator on our team. I'm going to give you a brief overview about what we're about to do. The RCMI program focuses on enhancing and developing necessary research infrastructure that ensures Howard University's ability to contribute to the resolution of diseases that disproportionately affect disadvantaged and minority populations. Our group, the Community Engagement Course, CEC, primary goal is to ensure that RCMI-supported research addresses the needs and interests of the local community. To achieve this, we partner with local community organizations to address health-related concerns, promote community participation in research and partnership with researchers in study design and execution, and we ensure research findings are shared with relevant communities. So tonight's conversation with you is critical to our work. The core is led by Dr. Carla Williams, and we thank you so much for being here. Karen?
Thank you so much, Ashley. Tonight, we are welcoming 4 individuals sharing perspectives and solid solutions at our roundtable. Our format is going to be a little different if you've been with us before. We will have 2 presenters, and we'll take a break, and then we'll have 2 more presenters, and we will be taking questions after each presentation. Be advised, this segment and the one that follows contain references to interpersonal violence and sudden bereavement. We will lead with Dr. Alex Henke, an associate professor in our economics department. Welcome, Dr. Henke.
Hello, everyone, and thanks for having me. Like Karen said, I'm Alex Henke, assistant professor of economics at Howard University, and I wanted to talk a little bit about some of the hidden costs of the COVID-19 pandemic, especially early on as it relates to intimate partner violence and mental health. So I'll be sharing some of my research with my colleague, Dr. Xu, who's also a member of the department, and also my separate research from my colleague, Dr. Grooms. Next slide. So first I want to talk about the mental health impacts of COVID. And so we're just going to be touching on a little bit of that, but obviously there have been significant strains placed on different people to different degrees. Next slide. So what Dr. Grooms and her colleagues find in some of their research is that Black and Latinx essential workers suffer more distress, especially anxiety and depression during the COVID-19 pandemic, more so than even just the overall effect, which is found among basically everyone. And then in a separate work, they find that basically what distance learning for K through 12 students means that parents become effectively proxy educators. And they find evidence that this leads to increased stress for the proxy educators. So when it comes to the policy that myself and Dr. Xu study, it's more about early COVID-19 lockdowns and related policies around COVID-19 and how that can impose other types of hidden costs among some groups. Next slide, thanks. So what we find, we look at early lockdowns and the fact that people voluntarily just chose to stay at home even before shelter-in-place orders were put into effect. We hypothesize that that basically this locks people together in the same small area, and normally that might be okay, or that might be a little extra stressful, but for some more violent couples, this can lead to more intimate partner violence. And then in addition to this, shelters, domestic violence shelters were also shutting down at the same time. So we test the hypothesis that that these early lockdowns especially lead to more intimate partner violence. Yeah, we can go to the next slide. Yeah, so this graph just really shows kind of relative rates of these variables, and the variables are just a rough measure of domestic violence, and then in terms of police reports of domestic violence, which has its limitations, of course, and then mobile device tracking data that shows whether people were at home all day. And so there's this really sharp coincidence in these standardized rates of these different variables. So what we're seeing here is that this vertical line is kind of the first lockdown in our sample. And so people started to stay at home, and that's exactly when we see an increase in these police reports of domestic violence, and then it kind of plateaus after that in this research. And so we estimate roughly that the rate at which people stay at home, that the fact that that increased is responsible for about a 5 or 6% increase in intimate partner violence police reports. And that could even be an underestimate because, you know, we don't measure all intimate partner violence. That's not possible. Next slide. Yeah, so later on, we did some follow-up research on this, and as the restrictions wound down, the IPV rate returned to normal, which is still not acceptable, but a lower amount, and the effect started to diminish, which provides some suggestive evidence that the most important thing here is, one of the big important factors here is domestic violence shelter resources. So that's the bad news. And then in other lockdown and COVID-19 related research, in the next slide, there is some, so some suggestive news. This is here. This is the fact that couples who work from home may not experience this impact as much. This may be due to a bargaining power effect of women who are able to leave the relationship if it becomes violent. And then the next slide is about the CARES Act, right? And so this is just a pivot towards the making sense of COVID-19. And one of the things that it did do was allow us to kind of run some policy experiments and see what big financial transfers could do. And so what we found for the CARES Act, which part of that was increasing the amount of money people got from unemployment insurance initially by $600 a week, which is a lot, like a very large amount when you're not making that much money. And what we find here, what this graph is basically showing is the weeks since the implementation. And so people anticipated the effect a little bit, but despite that, we're finding these big effects of decreasing crime rates, property and violent crime rates, after people start receiving this extra unemployment insurance money. So you put more money in people's pockets, you make them less desperate, and we're starting to find some positive effects of that in terms of basically this program partly paying for itself in terms of reducing crime, including homicides, I should say. And then these are some domestic violence resources that are local to DC.
Thank you, Dr. Henke. We're pausing here for questions. If there's anyone who has any questions, please feel free to drop it in the chat for Dr. Henke's presentation. I actually have a question while we are waiting. I wanted to know, Dr. Henke, you were talking about using police reporting of the intimate partner violence. And I'm wondering if there was any other source of reporting. I'm wondering if the local shelters or any sort of clearinghouse where those calls come in, but then I'm wondering if that is kept strictly confidential and maybe that's why it wasn't used. Can you speak to that a little, please?
Yeah, so like any research on intimate partner violence, the biggest thing, the biggest issue is going to be measuring the actual incidence of intimate partner violence. So one issue with shelter information is privacy. So there's a lot of concerns with some random researcher like myself having access to it. But the other concern in this particular case is that a lot of the shelters actually shut down at that time. So there's going to be this issue where they didn't record anything because they weren't open or they had more limited services sometimes. And so you might see recorded shelter incidents going down, but actually, even though the police calls were going up. One interesting thing about the police calls though, is you would kind of expect all reporting to go down because a lot of crime reports went down at the same time and police were specifically kind of not doing as much patrolling and stuff like that. But nonetheless, you're seeing more domestic violence calls. And so that's why we think maybe because of those limitations, it's an underestimate. Our estimate of the effect might be an underestimate.
Understood. Thank you. Does anyone else have any questions? I see a question in the chat from Dr. Carla Williams, and she says, say more, please, about couples working from home. We know domestic violence cuts across income levels, so having a job that can be done from home and may have higher wages wouldn't necessarily be protective. Are there any other explanations possible other than the ability to leave?
So there are a lot of plausible explanations, and there's a lot of follow-up work to be done to figure out which of those are actually the case, right? It's a lot harder to figure out exactly why things are going the way they are. One other plausible explanation would be that sometimes violent interactions are about the allocation of household labor, or sorry to say that more plainly, it's who is taking care of the kid, right? Who's doing the housework, right? And so if somebody actually is working not from home, then they have less time to do that. But it's possible, like you have an abusive relationship and the abuser has the person working from home do more of the work, but it doesn't rise to the level of a violent incident or something like that. So if there's more of a controlling relationship going on, that could also be happening. There's a lot of possible explanations.
And I have one last question. Is there a difference between domestic violence and intimate partner violence?
Right. So we usually like to be very specific about intimate partner violence if we can. So for this research, which was conducted in 2020, we were using the data that was available, which is individual city, cities just report their police calls to service. And so usually you can't separate exactly what the domestic violence call is about, but longer form research can more cleanly separate it and make sure it's actual like violence between two intimate partners, whereas domestic violence is just some sort of violence in the home.
Okay, so the victim can be anyone in the same.
Right, as long as it's being reported to the police. Yeah.
Okay, thank you very much. We're going to transition now and take a look at a very different and honestly very rarely discussed impact to our finances in the worst case scenario. And we will be taken through this by Ms. Dawn Brawley. She's going to guide us on an overview of managing the sudden expense of a funeral with the added complications of COVID. Ms. Brawley, the floor is yours.
Thank you so much, Karen, for allowing me to be here today. The first thing that we have to look at is that every year with rising costs, the cost of funerals go up. Unfortunately, a lot of us don't plan for that. It's not something we want to think about. And COVID has forced a lot of people to think about that, especially in a time where a number of people were out of work under the first lockdown. So I looked at some numbers just to get some averages for the funeral costs. And what I have listed there are the things that you absolutely have to have. You have to have your basic funeral staff and director services, plus your transport to the funeral home as the loved one is removed from wherever they took their final breath to the funeral home. So the average cost right now in Washington, D.C. is $9,000 for those services. In the state of Maryland, it's $10,100. In the Commonwealth of Virginia, it's $7,800. Now, those numbers were actually before COVID. Those are the latest numbers that we had before COVID. With COVID, there are going to be minimum upcharges because there are different ways of preparing the body and different protections that have to be taken. So expect a minimum upcharge of $500 if you're doing a cremation, or $1,000 for a full funeral if you're having a COVID-related death. Okay, next slide, please, Karen. It's always time sensitive when you're talking about the death of a loved one, but when you're dealing with COVID, it becomes that much quicker. With your standard embalming procedures practice, it has to happen within 48 hours from the time of death. And that was pre-COVID. When you're dealing with a COVID body, most funeral homes will try to bring that down to 36 hours if at all possible. After that 48-hour window, that body has got to be placed in a freezer. After 18 hours in the freezer, the prep time and the labor are going to increase substantially if you're planning on a funeral and burial rather than strict embalming. Okay. 50%, if you're someone you're looking at, 50% of your funeral home should be immediately available to avoid unnecessary expenses due to delays. And that's something that's just a reality that you can't get away from. Now, there are options available. You can have pre-planning or life insurance purchase is recommended to prevent added pressure on the bereaved. I want to talk about the pre-planning for a moment because a lot of people, again, we don't want to think about that. We all want to believe that we're going to live forever, and it's scary. The reality is that pre-planning is a way to kind of almost use layaway to pay for your funeral. It's a way to lock in your costs. You go into a funeral home, you make decisions while you are clear-headed and not in the midst of grief or under pressure where you're not able to really function, because grief changes how you function, how you think, how you feel, and the choices that you make. So to go in ahead of time and plan for the eventuality is always a positive if you can do it at all. It also gives you some opportunities to look at different financing options and put some things in place. Barring that, it's always a good thing to have a life insurance policy. Talk to an agent that you trust and sit down and look at what's possible within your budget. You can look at a plan that is strictly for funeral expenses and burial cost only, or you can look at a plan that will leave something for the family after the funeral. But regardless, you should look at, just for incidentals, keeping a minimum, if you're going to do life insurance, keep a minimum of $15,000 if you can at all, just to cover your bases. Next slide, please. As I said, local funeral homes do have pre-planning options. One of the best things about those is you get the opportunity to lock in your price. And as I said, you can make payments towards that balance, and they set it in an account that is actually interest bearing to cover the cost of inflation as well. Okay, so here are the burial assistance programs that are available locally. In the District of Columbia, they have $1,000 provided for a funeral, burial, or $650 for cremation. The total cost of the funeral services must be $2,000 or less. The requirements are that the decedent must be a resident of DC. The money available at the time of death can be no more than $1,000. That includes bank account, any stock options, any income that is coming from a spouse or anything like that. The total money available at the time of death is going to be no more than $1,000. All of those things will be considered. The burial arrangements are through approved funeral homes only that have contracts with the district for this. And of course, that the body has not been released to another funeral home at the time that you make the application. The ESA Burial Assistant Unit phone number is listed there. They have the 3 funeral homes that are approved by the district for this contract that you can call, and so you'll know who they are ahead of time. Now, the state of Maryland program will provide the cash benefit directly to the funeral director. Their requirements is that the decedent has to have been receiving public assistance or meet any of the eligibility criteria below. They're in foster care. They're on public assistance to adults. They're on temporary cash assistance, or they're on the temporary disability assistance program. Any questions about this, the best answer for this would be from your caseworker, and they'll be able to answer more specific criteria as they look at each case as it comes in. The Maryland Burial Assistance number is 800-332-6347. Now, unfortunately, the Commonwealth of Virginia does not sponsor any programs at this time. Depending on the jurisdiction, there may be local funds available through different programs, but those are private programs. And again, it's going to be based on local jurisdiction of where the decedent was residing. Next slide, please. For federal assistance, FEMA is continuing their program, and right now they are providing up to $9,000 in reimbursement of expenses. Let me reiterate that it's reimbursement only. You will still need to pay for the charges, and FEMA will reimburse. There are some requirements. You have to have the official death certificate that lists COVID-19 as a cause of death. It may not be the only cause of death, but it has to be listed on the death certificate for FEMA to even consider it. The death must have occurred in the United States. It could not have been traveling or anything else, or acquired COVID-19 in another country and died in another country. It has to be here. Absolutely have to have a signed funeral home contract that has line by line cost outline. Some of the things that are covered with that particular program, again, the services of the funeral director and the staff, the removal of the body, transportation for 2 people to the funeral home, the cost to produce the death certificates, the cost of the burial itself, the transfer of the remains, if there's a casket or an urn, the burial plot, the marker, and the headstone, any funeral equipment and staff, those will all be covered. But again, they have to be itemized line by line on that signed funeral contract, and a copy of that, along with all funds outlaid for that, have to be turned into FEMA in order to receive anything. Applications have to be completed by phone, and that number is 844-684-6333. That's Monday through Friday, 9 a.m. to 9 p.m. Eastern Standard Time. Next one, please. So some of the things that we look at for grief management for COVID: designate someone that you can check in with every few days. There are a couple of reasons for do that. 1, general health reasons, but 2, because the depression and anger and grief can really become paralyzing. Secondly, try to maintain good sleep habits. If we're not sleeping well, then our body begins to break down, and that puts us at greater risk for COVID itself. Thirdly, eat regular meals, even when you don't have an appetite. Same thing. Again, you don't want your body to begin to break down and make you vulnerable. And also, it kind of puts you in this whole vicious cycle. If you're not eating, you feel worse. The worse you feel, the less you want to eat. So even when you don't have an appetite, at some point, force yourself to get on a regular eating schedule. Most importantly, know that the anger phase of grief with this may be much longer and more intense than in previous times of grief, because for the last reason that it may not always be safe to gather as we normally do for a celebration. So you have to follow local guidelines. Okay, next slide.
We do have a question that popped up in the chat, Dawn. That's all right. It's about the FEMA program, and Ms. Holmes is asking whether the FEMA program is permanent, and if not, when does it expire?
As of right now, there has been no legislation that says it's permanent, and they haven't given us a deadline but we know it's coming. We just don't know when. But at some point, we know that they're going to lift the state of emergency for the pandemic. And at that time, typically when they do that, they'll probably give a 30-day window beyond that point in time to receive any reimbursement requests.
I have a follow-up question to that, and that is, I'm guessing that it's supposed to expire when the pandemic is officially lifted. Does that mean that there can be a retroactive request back to when the emergency was first called?
Yes, They have actually been going back. So people are going back retroactively to, I believe it's saying January of 2020. So if you have anything, if you still have death certificates from that, you can still go ahead and request and apply for your reimbursement at that time. You just have to have all of your documentation. Also, since you mentioned the retroactive request, if there was some question or concern, talk to the doctor who signed the death certificate and ask for their notes. And if there's anything that they say that mentioned COVID-19, turn that in. If it's not on the death certificate, but they have it in their notes, err on the side of caution, ask the doctor for a copy of their notes and say that, you know what, I'm requesting this information from this reimbursement and I need the documentation.
There are a couple of more questions coming up. One, as you're speaking of requesting information from the treating physician or the physician who signed off on the death certificate, is there a restriction on who can request this information?
Typically what happens, because they are dead, that's going to be limited to the next of kin, unless the next of kin is a minor, and then it would be the next adult who is closest in age. But because of the government program, they are loosening up some of the rules around HIPAA and the protected health information, because this is necessary for that program.
Okay. We have another question. Are there income limits to receiving the FEMA benefit?
There are not.
Here's another question coming forward. At what age do you recommend that individuals begin pre-planning for their funeral? That's the first part.
Okay, and I'll answer that, the sooner the better. Accidents happen all day long. It's unfortunate. I've had to go through sitting with families and dealing with funerals for children as young as 6 years old behind accidents. So the earlier you can plan for it, after you become an adult, definitely, if you can do it at age 25, do it at age 25. Put it on your to-do list I know we've all seen those lists. Things you should do by age 25, things you should do by age 30. Add planning your funeral, planning for payment of your funeral. Add that to the list. It's always helpful. The earlier you get it done, the more time you have to stretch out that financial payment over time if you're going to use a payment plan. Okay.
And the second part to that question from Ms. Holmes is, what tactics would you recommend to start such a sensitive conversation within families?
Okay. This one is, Ms. Holmes, thank you for that question. First of all, this one's always difficult because every family is different. But one of the things I always tell everyone is, we always talk about having a plan, having a life plan, having a 5-year plan. But when you talk about having a life plan, even though none of us are willing to admit it, death is still an integral part of life. So of course it needs to be part of that plan. So it's one of the things that I do is I always ask families, well, have you thought when you bring them in, if there's someone close to them and they ask, well, I'm worried about how so-and-so is going to handle this. I was like, okay, and do you have a plan in place for how you're going to handle this from both an emotional standpoint and a financial standpoint if this comes apart quickly because they don't handle this well? That's generally how I go in. When I have younger family members coming in and talking about their parents and feeling so lost, one of the things that I asked them, I said, I understand this is difficult. Do you have a plan in place to avoid your child having to go through this? And that's how I approach it, with an eye towards looking for the future.
I have a question myself, and that is, you mentioned in this last point about understanding that it might not be safe to gather as is customary for celebration. can you talk about, since I'm imagining that you've had to handle a major uptick in these types of conversations, how do you approach talking to people about not gathering and mourning the way they feel like they need to, especially since if the decedent has died of COVID, they're not likely to have been, they were probably isolated in those last days. So how do you work with people on that?
That one's always hard. The first thing that I do is tell them they're allowed to be angry, because most of the time they walk into the funeral home angry. And I give them a safe space to feel that anger. And I said, I understand. I said, because you didn't get to say your goodbyes. And that's difficult. And that makes everything that you're feeling now that much worse. This is a safe space. Be angry. And I heard quite a bit, a lot of people say, you know, nobody ever told me it was okay to be angry at this right now. I said, it is. Whatever you're feeling, it's okay. I said, and suppressing that is going to make everything worse. I said, especially because we have to deal with the reality that right now we cannot have everyone around us and grieve like we normally would. So we have to be very conscious of that as well. And that's another point of anger. So let's get that out right now in my office where it's a safe place.
And what about the not being okay with not being able to have a big, celebration?
Right. And that's one of the things that I told them. I said, you know, we do have to limit the number of people. I said, we do have to follow state guidelines. But one of the things that I would also tell them is we will have a Zoom link set up so that even though people cannot physically be in the space, we still have options prepared so that they can participate. And we've done that. It's not always easy. It's not always ideal, but it has provided some measure of comfort in the midst of this. And then we've always offered the option to later on have a memorial service once it's safe for everyone to gather.
I mean, I would guess that this is a particularly relevant conversation since we're finding ourselves in another nationwide surge and people are just not cognizant or I have another question that's come up in the chat, but I'm not sure to whom it's directed. So I'll place it to the floor and either you, Ms. Brawley, or Dr. Henke can respond. The question is from Mr. Holmes. Do you have advice for how to prepare for financial impact of the mental health issues that arise in the household due to COVID?
Okay. Well, Dr. Hickey, if you don't mind, I'll look at this from how we did it from our funeral home's standpoint. We did have a professional bereavement team that with licensed professionals that was part of every service. Every family got a certain number of visits with the bereavement team. And that was included. And then if they wished to go ahead and go forward at that point, they could use their insurance and file with that. But that was one of the ways that we as a community chose to make sure that each family had help in managing their grief by building it into the cost, into one of those costs that absolutely has to happen as the basic cost of the funeral director and staff. So we built in that cost so that they had that mental health protection. Beyond that is if you have insurance, read your plan and know what your plan says about it up front, how many visits you're allowed, to whom they are allowed, and what the cost will be. And know that up front. And that's not just with COVID, but that's all the time, because as you said, we have dealt with some challenges with this mass shootings coming more rapidly. So that is always something to be said. That's one way to prepare for it. Dr. Henke, I will defer to you for any additional information if you have it.
No, I think that was a very good response. Thank you.
Okay, if there are, okay, so Mr. Holmes has confirmed that's what he was getting at. He said mental health may be ignored by families due to financial stress and fear. Okay, well, thank you very much for that insightful presentation. I cannot imagine what types of burdens people come to you with on the daily, and just the stress of having to deal with the suddenness. But, oh, you know what? I do have a question, actually. Back to that 48 hours.
Yes,
and given that it just may not be possible for people to have had the pre-planning, and it's just sudden, they hadn't thought about it. It wasn't on the 5-year list, the 10-year list, or the anything list. What would you say to people who try to crowdsource or crowdfund, as we're seeing a little bit more often now? How does that translate to the timeliness of the need?
it doesn't. I'm going to be quite honest. It doesn't. There's so much paperwork and lag time that you have to go through to even be able to access the funds. Most funeral homes have written into their contract that after a certain amount of time, usually 30 to 45 days, any unpaid balance begins accruing interest. When you do the crowdsourcing and things like that, most of the programs that we've seen, when folks have tried to do that, if they leave it open, there's usually a 30-day wait time before they can access the funds. From the time that they close it, there's generally a 30-day wait time, unless they've had it set up before that ahead of time. So because they're now cracking down much more on who can use them and under what circumstances that you can. So it creates a problem, because you're still sitting there with funds accumulating and, with interest accumulating and not having the funds to pay for it. So in those situations, I tell families a lot of times, you may need to rethink the options of how you want to send your loved one off. It may be time to think that a full burial and funeral service with viewing and all of that may not necessarily be financially feasible. It's unfortunate, but sometimes you do have to have those conversations, particularly if they're telling you that there is someone else who's also dealing with several health challenges at the same time.
Oh, in the family, you mean?
Mm-hmm.
Okay. Well, sorry to have held you, but there were a number of questions that came up, and is there, for any of our speakers, really, I would encourage our guests, if you had additional questions, because we are dealing with a lot of information today, please go on ahead and submit your questions, concerns, requests for more information in the chat. Each of our speakers does have access to the chat. They can see you, and they will put their contact information as well in the chat as it's appropriate for further questions and information. And with that, I think we're going to take a little 2-minute break in between our sessions. During that time, feel free to turn off your camera, step away, turn off your mic, breathe deeply, and possibly consider a study opportunity that we do have at Howard University. After we're done this evening, you will be invited when we send our follow-up information to participate in an online survey. And that's to help us understand what is important about life beyond COVID-19. It is a nationwide study, and you will be helping researchers find the best ways to share information. And by participating, you would be eligible to receive a gift card up to $100. And that is dependent on how much of the survey you end up completing. If you'd like more information about that, you can email us at rcmi-cec@howard.edu, and we will place that email in the chat as well. We will be back in 2 minutes. Welcome back, everyone. Thanks for your questions beforehand. We do have our email in the chat, rcmi-cec@howard.edu. If you have any questions about the study, if you have any questions about our presentations, any questions whatsoever, please feel free to reach out to us. We have a whole team of people ready to assist. We are going to move on with Dr. Tracy Faulkner, who is a pharmacist, and she will be diving into perspectives of what contracting and having to treat COVID may cost you, the individual. Please welcome her.
Off mute. Good evening. Thanks so much for having me participate in this panel discussion. I bring a perspective to this presentation in multiple capacities. One, as a clinical pharmacist, also as a pharmacist who has been a part of the emergency response and working with an area health department. So I've had the opportunity to actually speak with individuals who have tested positive or their actual contacts, people just calling for all kinds of questions relating to coronavirus. Okay. So what could contracting COVID cost you? This first slide that you see looks quite busy, However, what I decided to do was to present information based on the area, since we call this the DMV, the District of Columbia, you have Maryland and Virginia. So this particular slide is from Fair Health, and they're providing information from all of the states based on the medical cost and hospitalization cost for coronavirus. Now, there are three categories here. If you look at the slide, to our left, we see COVID-19 complex inpatients. So these are people that are hospitalized, and I know either if you haven't contracted coronavirus, you happen to know someone that has had coronavirus and may have succumbed to the illness. A complex inpatient is someone who's been hospitalized, admitted to a hospital. They required being in an intensive care unit, or we like to say ICU. They required a ventilation for breathing support, extensive medical care, or they like to call it complicated care. The middle burgundy diagram is the non-complex inpatient. So this is someone who contracted coronavirus, tested positive for coronavirus, and was admitted to the hospital. However, they did not require a ventilator, and they did not have to be admitted to the ICU. So they may have just been on a COVID floor in the hospital. And these costs include room and board, as well as lab testing, imaging, all the costs that were a part of being in the hospital. The blue columns are someone that's an outpatient. So say, for instance, someone tested positive for coronavirus and has symptoms. They did not require having to go to the hospital. So they may have just gone to urgent care, may have gone to the ER, had testing done. These are these costs. And again, I know this slide looks very busy, but if you can imagine, if you've ever seen an insurance bill, or what we like to call an EOB, or explanation of benefits, there's usually the charges, what the actual institution charged. Then you'll see what the insurance company, the allowed amount. So this is what they're going to say, okay, we're going to pay this. And then there may be additional costs that you pay, or they like to say your responsibility to pay, or those costs may be written off, or you're not responsible for paying. So that's why this slide looks a little busy. So on the left, if you had an inpatient, required ventilation, ICU, the average cost in the District of Columbia that an institution may have charged was over $270,000. Okay, now you see an average charge and you see a median charge. So the average is, okay, we're going to take the range of all the average charges for the institutions in the District of Columbia, and we're going to take the average, and that's how this number was calculated. Now, the median amount that you see here for someone that's been in the ICU, ventilation, all the extensive complicated care that was provided, they'll say, okay, we're going to take all the range of numbers of charges and what's in the middle. So that's how you develop the median. And I hope that explains it clearly. But again, this just looks similar to what you see with your electronic bills, or you actually may receive paper bills from your insurance companies. And this is what this all means. So if someone, a complicated case, over $270,000 was the average amount that was charged. Insurance companies or federally funded companies only paid $83,000 of those amounts. And if someone knows more extensively about how billing goes, in certain instances, institutions weren't allowed to charge you the balance. But in some instances, depending on if you had commercial insurance, you may have been charged an amount that you had to pay. Okay. If someone is just an inpatient, didn't have to have ICU, the average charge was $44,000. The estimated allowed amount to be charged was $18,000. So you can see a difference of $30,000. And if you're outpatient, The charges may be $2,500. However, the amount that was allowed to be billed to insurance or to a federally funded entity was a little less than $1,000. Okay, so this is for the District of Columbia. So now let's take a look at what were the charges from Maryland. As you can see, anywhere from $130,000 complex patient to an outpatient of $1,500, and the estimated allowed amount outpatient was $580. Okay, and now let's look at Virginia. This number will be even less. Okay, now for complex patients, like someone that may have been at Inova Fairfax Hospital in the ICU, over $280,000. If someone was hospitalized without ventilation, having to be in the ICU, the charged amount may have been nearly $50,000. However, the estimated allowed amount to be charged or that was paid was about $18,000. If you're an outpatient, the charges of the estimated allowed amount to be charged was about $850. Next slide. So this slide may look a little crowded, but we're going to talk a little bit about long COVID. So these are people that have symptoms related to coronavirus after 28 days or so. Some people have symptoms for a short amount of time. Some people have them for months. We are now coming up past 2 years since the pandemic. The people are still having symptoms from coronavirus. And I like to say that coronavirus actually affects us from head to toe. If we start in the brain, you may have experienced or you know someone that experienced brain fog. They're forever forgetting things. They just don't remember. They're extremely tired. There are some psychological issues, unfortunately, that people may experience. PTSD, some people are afraid they're going to contract the virus again. Insomnia, that can be related to anxiety or any behavioral health issues, or it may just be that that particular sleep center has been affected by coronavirus, by some mechanism. You hear of people that have had problems with their heart, whether it's myocarditis, or there's some people that have had strokes related to clotting issues, that have had heart attacks related to secondary to coronavirus. Impaired lung function. I have to say that the organ that is the most affected in coronavirus are the lungs. Some people have become candidates for lung transplants or have received lung transplants secondary to coronavirus. I like to say we start at the brain, we go to the lungs, then we talk about the heart, and next the kidneys. Some individuals have impaired kidney function to the point of needing renal replacement therapy, such as hemodialysis. Could be a healthy individual, had no health issues whatsoever, contracted coronavirus, and unfortunately have some long-term effects. I do know of people that have actually received kidney transplants secondary to having contracted coronavirus. During the pandemic and the shutdowns, oftentimes medical visits were delayed, whether they were televisits or they were just postponed. We've seen a worsening of chronic issues such as hypertension, diabetes, high cholesterol, arthritis, GI disease, delays with diagnoses of cancer. And again, that's not related to long COVID, but I'm kind of integrating that into this discussion. There's some people that are always tired, and they never were like that prior to having had coronavirus. And also impaired daily function or movement. Like we've seen stories even on 60 Minutes, or we know of people that were athletes, were marathon runners, and now it takes their breath away just to walk from one side of the room to the other. Next slide, Parker. Thank you. Something else that has been documented with research has been a surge in the number of individuals that are being diagnosed with diabetes type 2, and that is your what we like to refer to as your insulin independent diabetes. And there are multiple reasons for that. One is they seem to think that because we know coronavirus, we hear the word cytokine storm, You also have, it's a stressor. It's a major stressor. The entire body is inflamed. So what happens when we're stressed? You have that fight or flight syndrome. The body is, if the person is receiving steroids as a part of their treatment, that increases your blood glucose levels. The body's not responding to insulin levels that you may have needed prior to, or you never needed it, but in a critical state such as this virus presents, people are developing diabetes. I see at the bottom of this slide, who are some groups that are most likely to be predisposed to diabetes? Well, individuals with sedentary lifestyles. As far as ethnicity, African Americans are more predisposed to diabetes. Also, our Hispanic population, some Pacific Islanders, some Asian Americans also at increased risk for diabetes, are Native Americans. And again, this is just some of the groups that are predisposed. If you're obese, that is also a risk factor for developing diabetes. And the study that's mentioned here was in a group of veterans, and they noticed that prior to coronavirus, they didn't have diabetes, but afterwards, they're seeing that they have developed diabetes, or in some instances, they may have had diabetes and they're having to use an increasing amount of medications to treat their diabetes. Next slide. So as far as cost, having long COVID, it's also called post-acute sequelae of coronavirus, your healthcare team may increase. You may have just had a primary care physician or may not have even had a medical team. But again, with all the sequelae or complications from coronavirus, people need to see a pulmonologist or a lung specialist. There are fees for that. And a lot of our specialists, there weren't as many. So now you have all these individuals who have tested positive or who have long COVID that need a specialist. So there may be a delay in actually having an appointment with those specialists. You can always use the pharmacist for certain things. You may need a cardiologist, definitely a nephrologist, kidney specialist. There's almost a wait to actually see a kidney specialist. Infectious disease, these are individuals that are going to follow you after having had coronavirus. You may have other illnesses that coronavirus is actually complicated. Treatment plans, again, diabetes endocrinologist, it's either a primary care physician, endocrinologist, a diabetes specialist, you name it. There are long wait times for appointments, unfortunately, even through televisits. Radiologists for imaging, a lot of individuals have long-term sequelae from lung damage. So having imaging, whether it's x-rays, CTs, MRs, again, there are oftentimes a wait time to even have imaging done. When we talked about brain fog, neurology, with clotting issues, some people have developed or have had, unfortunately, had strokes. So there's an increased need for a neurologist. Neuropsych is more of individuals to look at cognitive functions like memory. Then also not mentioned like occupational therapy, physical therapy, and the team, again, just you go for maybe just one doctor not having any, any members of your healthcare team to having look at all these people that are now a part of your healthcare team. And there has been legislation that is to classify coronavirus as a disability. Okay, next slide. Thank you. Okay, now regarding medications and treatments, you see 4 drugs that are listed here. Paxlovid, we've heard a lot about. Once our vice president tested positive for coronavirus, she actually took the oral antiviral Paxlovid, and a partner to that is Levero. Those 2 drugs are actually available in what's called our Test to Treat program. So the US government has purchased these products from Pfizer and Merck respectively. And if you test positive for coronavirus and you don't require hospitalization, your primary care physician may prescribe this medication to you. And currently, there's no out-of-pocket cost for these 2 medications for coronavirus. And now Evusheld, if you hear us talk about people that have a suppressed immune system, this is an injectable drug that has also been purchased from AstraZeneca as a preventative measure. So these individuals have a suppressed immune system, transplant patients, people that take monoclonal antibody treatments for rheumatoid arthritis or different GI diseases, may be eligible to receive this in addition to vaccines, of course. And again, there are no out-of-pocket cost for Evusheld. If you go to a site, COVID19therapeutics.com, you can actually find where these medications are. If your physician doesn't prescribe it to you directly, then you can find out where it's being distributed. Going back to Paxlovid, that actually, I did some research and actually spoke with a care provider in the District of Columbia, and there are certain clinics throughout the District of Columbia that actually provide the drug once you have a test or you take in confirmation that you've actually tested positive for coronavirus, and they can actually dispense or give you the medication for your treatment. It's usually either a 5-day treatment. Okay, Veklury, we heard about this drug as remdesivir. These are all haven't been approved by the FDA. They are being used through an emergency use authorization. Okay, so we're using these to either prevent and or treat coronavirus. Okay, so again, no charges for these. And again, like Don mentioned earlier, these medications are being provided through the federal government. So say, for instance, if you have commercial insurance, again, there are no out-of-pocket costs to you. For the injectables, there may be an administrative fee that's charged to your insurance company, but for the drug itself, there is no copay. There are no charges to you directly. If you have a federally funded insurance company, such as Medicare, Medicaid, now those programs, you can receive the drug as well. And again, there are no administrative costs or anything to you. If they are, they're billed to the insurance company. Okay. If you have commercial insurance, those plans can provide coverage for the medication. If there is a need for a patient assistance program, you may be eligible. But if you receive TRICARE through Department of Defense, Medicare or Medicaid, then you're not eligible for patient assistance programs. So just wanted to make sure that you're aware of that. Because these medications have not been FDA approved, the patient assistance programs may not have been established as yet. The patient assistance programs are for individuals, for drugs, that have been approved by the FDA for an indication or a condition. Okay. Next slide. A lot of information, and there's so many costs. Are there any questions? I'll do my best to answer.
Thank you. Thank you very much. That was really informative, Dr. Faulkner. And we did have a lot of chat actually happening in the window while you were speaking. And it looks like Mr. Johnson responded because what you were talking about kind of overlaps with his topic, Medicare and Medicaid. But the first question was, who takes up the slack for the large difference between charges and estimated allowed amounts? That's the first part. And then the second part was, are hospital financial assistance programs included in the estimated allowed amounts?
Okay, I thank you for the question, Miss Alicia. I'll answer the second question first. The hospital financial assistance programs are not included in the estimated allowed amounts to the best of my ability. I actually called different hospitals just to get an idea of kind of what goes on in the area, because again, my knowledge regarding expenses, I've come from the health department. I've been working there for almost 2 years, so totally oblivious to kind of what goes on outside, or I'm not up to date on that. But I know that there are some financial assistance programs. And again, I know of cases where with the CARES Act, you weren't to have any out-of-pocket cost at all. You know, they were basically, the hospitals were being reimbursed the allowed amounts. Okay, and that, but again, those things have changed because to the best of my ability, and if someone knows differently, those programs have ended or those funds are no longer available. So there are hospital assistance programs that are now can be utilized. Okay, who makes up the slack when the difference between the actual charges of the hospital and the estimated allowed amounts? In some instances, I know insurance is usually 80%, 20% in some instances. So you can be charged those amounts. Sometimes it's a write-off. Again, I'm going to limit my response on that because I'm not really sure. But again, I do know in instances where some hospitals are profit and some are not for profit, and they have other charities or other nonprofits that can contribute to those amounts or differences. But again, all of it's a little different with coronavirus because of the CARES Act. And again, a lot of those funds were specific by the states and some things were federal. So a lot of those programs are ending. So I don't know if I answered it appropriately, but that's to the best of my recollection in talking with different billing departments at different institutions. Okay.
Definitely, Mr. Johnson actually had some commentary about that mirrors what you're saying, and I'm sure that he will be speaking a little bit more about the CARES Act in his piece. But I just want to make sure that people have had the opportunity to check in with you about your presentation, and if there are any further questions. I do have my eye on the time. We have gone slightly over, but I also see that we still have most of the people who were with us at 7 are still with us. So thank you for remaining with us. We do have one more speaker, and he's bringing up the rear because he has some really solid information about Medicare and Medicaid. So without any further hesitation, I bring you Mr. Shane Johnson. He's going to be talking about the financial impact per person on Medicare and Medicaid.
And if I may, thank you, Mr. Johnson, for answering those questions. We appreciate you.
I appreciate you. Well, I mean, I actually appreciate all of you because I've learned a lot. So thank you. So my name is Shane Johnson, and just a little bit about me. So I am a principal at TDMP Consulting, which is a catastrophic injury cost litigation management firm. I'm also the state director of a Medicaid waiver program that focuses on self-direction, and I have worked in Medicaid for some years. So I want to go ahead and talk a little bit about federal and state care. So basically what we're talking about is the difference between Medicaid and Medicare. They are both public insurance programs, but Medicare is particularly federal. And let me go ahead and I'll follow the slide. So we're going to talk about Medicaid and Medicare, and I'm not going to be before you that long. We're going to talk about the 21st Century Cures Act because that part is important. A lot of people have been mentioning the public health emergency. We are anticipating the end of it, and I'll tell you a little bit more about that because it did have an impact on both of those public insurance programs. But what I would like to focus on is the home and community-based services waiver programs. So let's go ahead and next slide, Karen, please. So the difference between Medicaid and Medicare, Medicare generally covers people who are 65 years and older, disabled persons of any age, anyone who has received the social supplemental security disability income or diagnosed with end-stage renal disease. ALS was added in 2020. The long-term COVID conditions, the PSC that Dr. Faulkner brought up, there's guidance from HHS, but the Social Security Administration has not provided a position on whether or not that's going to qualify as an SSDI condition. It probably will. I didn't want to put that in writing. I just wanted to let you know that I did look at that. There's not a statement for it yet. The same everywhere in the US. So Medicare is Medicare wherever you go. There are differences in the offerings because many states can have their own Medicaid Advantage plans, but that's generally more company driven. And then there are some subsets of programs that will vary from state to state, like PACE, and that's the program All-Inclusive Care for the Elderly. But it's really run by a federal government agency. How Medicaid differs from that is that Medicaid covers pretty much everybody else. So children, elders, people who are low income, able-bodied adults in some places, persons with disabilities, usually the result of receiving SSI because you automatically qualify for it, and then pregnant women who are also nursing. It is also the U.S. largest source of healthcare coverage for mental health, long-term care, and births, and in some jurisdictions, dental care, because there are certain Medicaid plans that have a dental benefit for adults, not just children. The eligibility for Medicare, though, is very different because it varies from state to state. So it's run by states and U.S. territories, sometimes local governments. You see that type of arrangement in the state of California, where there's a partnership generally between Medi-Cal, but also the county acting as a health authority, and they create their own health plan. Next slide, please. And the 21st Century Cures Act. So there were a few things that ended up happening with the 21st Century Cures Act. It happened in like a few waves. So the first, I think, came through in like 2016, 2017, something like that. So there was an increase for funding for Medicare and Medicaid, but also for new product and new medication development. It also broadened the eligibility criteria for Medicaid and Medicaid waiver programs during the public health emergency. It also relaxed a lot of the requirements for recertification. Because if you're familiar with Medicaid, or if you're not, every year, what ends up happening is that a person has to recertify for Medicaid. In some places, it's every 6 months. In a place like Alabama, I think it used to be every month. It just depends on where you are. And like I said, Medicaid varies, from state to state. It also allowed for more treatment options that multiple providers could bill for. So telehealth, video conferencing. It enhanced provider reimbursement rates, in particular home health rates. It also enhanced hospital reimbursement rates. So if hospitals were taking care of an aggregate amount of COVID beneficiaries or people who were suffering from the symptoms attributed to COVID, then those hospitals actually ended up getting an enhanced payment rate for those hospital stays. It also enhanced personal care attendant pay for home health in some states. It really depends, again, on what those states decided to do for, and what those states tried to use that money for in terms of reimbursement. They did have wide latitude to use that money for other things. And I thought there was one other slide, but that's okay. It's missing. So I want to say this because I'm going to drop this in the chat real quick. And I do want to talk a little bit about self-direction because I think it kind of ties in to a number of presentations that people had talked about. So at the beginning of the public health emergency, and I'm going to go ahead and put all of the home and community-based services waiver program information in there. That was the last slide, as a matter of fact. So let me just go ahead and give you that one real quick. And then I'm going to go ahead and drop this in the chat.
Thank you.
Mm-hmm. Okay, so if the home and community-based services waiver program actually was instrumental in helping people who had been displaced because of the massive closings that occurred at the beginning of the public health emergency. And if you were a person who had to serve as a caregiver for a person who was living with symptoms attributable to COVID, you were able to actually take your person who was on Medicaid, sometimes a dual eligible, go to one of these 3 agencies that you see here, see if they have a self-direction program. And if they did, you could serve as that person's caregiver and you would be paid an hourly rate based on the personal care attendant services rate in the jurisdiction. DC has one of the highest rates in the nation, but other states do too. But I just wanted to let you know that was one of those ways that people who were displaced, at least economically from COVID, were able to actually pick up a different skill set by taking care of a loved one who was living with a particular disease process, in particular COVID.
So there is a question coming up in the chat. I think that you can see it. Once
Sure.
the eligibility requirements become more strict, when we come out of the public health emergency, what will happen to those who are utilizing Medicaid? And I'll stop there.
Okay, so the first part of that question, and thank you very much, that is going to be a real tough pickle for states that have, how do I want to say this? Because I don't want to make this one of those discussions. But I do have to say that in certain states that have a tendency to be a little bit more conservative, that wide latitude of the money that they got that was supposed to go into Medicaid that I talked about, those states are no longer going to receive that money. And as a result, the people who did come into that net of eligibility for Medicaid are going to be precluded from participating in Medicaid. DC is not one of those places. Maryland is not one of those places, but leadership in Virginia has changed and Virginia may become one of those places. Does that make sense? Without me. Okay.
Not only does it make sense, it's frightening.
It is. It definitely is. Are there states or places, and it says the other part of the question is, are there other programs like safety net clinics that can assist those who no longer qualify for Medicaid but cannot afford private insurance? Excellent question, and the answer is yes. So federally qualified health centers are able to provide ongoing care to people who are uninsured. The other thing is that in Washington, D.C., we have a number of programs for people who are uninsured, but the way that D.C.'s Medicaid program works is that there is a lot of flexibility in eligibility. And in terms of Washington, D.C., even outside of the public health emergency, eligibility for Medicaid was still pretty high in terms of the amount of money one would have to have, because Medicaid is based on resources and disability. So for people who cannot afford private insurance, but also don't qualify for Medicaid, we still have something called the Affordable Care Act. And there still, in many places, exists subsidies for those who cannot afford to purchase private insurance from the healthcare exchanges. So the Cures Act didn't get rid of the Affordable Care Act. If anything, what it did was it augmented some of the benefits and provisions that already exist in the Affordable Care Act. Now, that may change because, again, like I said, we have a Supreme Court that's a little bit different. There were a couple of cases that were presented to the SCOTUS that tried to get rid of the guaranteed issue. Those were not successful, but again, we now have a court that has 6 conservative justices and 3 not conservative justices. And if someone decides to mount a legal challenge against the guaranteed issue or even the subsidy, there is a possibility that it can go away. As it stands right now, though, we still have the ability to access those subsidies in certain jurisdictions because, again, remember, states also have some latitude in changing how that's actually done. And there's something else that I want to mention is that in other states, they have something called a 1332 waiver, which has to do with the implementation of private insurance programs. And that's also something that we can talk more about. I'll put my email address in the chat. So if you do have any questions, I'm more than happy to go ahead and answer them for you. And I'm sorry that I kind of rushed through this. I just wanted to make sure that I wasn't bombarding you with a lot of information because this is something I can talk about all day long. So I hope I answered your question.
I think that certainly if there's anything that's discussed today, we came in with the understanding that this was going to be a lot of information, and it's almost like what we like to say around RCMI, like drinking from a fire hose. But we thought that as we were talking about the various types of impact of COVID, regardless of where you come from, if you were alive and breathing in 2020 and you still are now, you have a story about how your money looks different now than how it did. And some of us have worse stories than others. You do have another question, Mr. Johnson, in the chat. Do you advise individuals on their options, especially in Virginia? And I don't know if that's a question of whether you do that for your business or that's the question that's in the chat.
The short answer is I provide knowledge to people for them to make sound decisions. I do not advise people on any particular path forward. I like sharing this information with people just because I think it's important to know how insurance works, how programs work. And if I don't know the answer, I am certainly not scared to go and find it. So I can certainly help you with that too if you have any questions about that. But my expertise is in DC's Medicaid program. I'm learning more about Virginia and Maryland. But if you need some help, I can certainly go ahead and provide my information to you.
Dr. Faulkner has raised her hand. It looks like she has a question. Please go ahead and come off mic.
Mr. Johnson, your presentation is superb. So thank you so much for your information. Do you happen to have an idea as to when funding will end for care? And what I mean by that is, like I talked about medications, right now they're covered, by the federal government. There's no out-of-pocket expense unless it's an injectable. You may have an administrative fee. Right. But again, if you when, do you have any idea as to when those programs will end? Is it when they've exhausted funds, when Congress, votes again or says that we can extend this, or does it end when we're no longer considered a pandemic and this is endemic? Do you have any time frame?
I wish I did. So here's what I know. So currently the federal government still says that we are under a public health emergency. Right. Once the public health emergency ends, we are supposed to get a 60-day notice for the end. Now, we also have to remember that while in our heads, we think that this is ending because we've been in this for 2.5 years, we have BA2, which is spiking.
All over the country.
Hospitalizations are spiking amongst the vaccinated and boosted. Right. And we are, sorry, hold on. I don't know what's wrong with my keyboard. Okay, Sorry about that. All right, can you hear me now?
We can hear you.
Okay, great. So, yeah, so we don't know exactly when this is going to end. If I had a crystal ball or something that I could go ahead and say, yes, this is definitely going to happen, then sure. But as it stands right now, there's a ton of money out there. It's being spent on treatments, and will spent until, come on, y'all. It will wait until it's time for me to answer a question that's really important. Okay, there we go. All right. So, again, we don't know. What I do know is that even with the end of the public health emergency, there's still going to be a need to treat all of these people who are still long sufferers from the clinical complications of SARS-CoV-19. This is going to be around. So in the same way that we have to care for people with chronic conditions like cardiovascular disease, HIV, diabetes, this is going to be something that we have to take care of, because if we don't, on the front end, it's cheaper to go ahead and take care of preventive care and manageable chronic conditions than it is to pay millions of dollars for hospitalizations.
Agreed.
Thank you. I have another question, if I may, and let me know when I need to end, Ms. Parker.
I still have a room full of people who seem to really be engaged in this conversation, and I'm thrilled, really, very appreciative of everyone's time and effort that you've put into this. This is really something. So please continue if you can.
I just like to, I know we kind of went through, there's a lot when it comes to cost of coronavirus. I just wanted to inform people of some of the cost when these programs do end, like say for instance, the Paxlovid or the oral antiviral medications. The cost of those when these programs end for a course for 3 days or 5 days is anywhere from $530 to $700 for the treatment of oral meds. The injectables, I actually talk with the companies. And again, if the government has purchased it, they weren't willing to provide costs. So I just said, may I just have a retail price, of these medications? If it's an injectable, it starts at about $2,000. So if you don't have commercial insurance or a federally funded insurance, then are you going to have to make a choice between, okay, I take this medicine for 5 days or 10 days or whatever the rules are. If I test positive, that's a lot of money. Are you going to have to make choices between purchasing food? I mean, and let's just say you have it and you have to isolate. You're going to have someone to deliver food to you or, whatever you need. And a lot of health departments are ending their programs, whereas you could receive community resources like cleaning supplies or, just basic meds, cold products, and the like, a thermometer, Lysol wipes and these things. What's a person to do?
Well, I'm going to ask my health providers in the room about their perspective on that very question. I'm sorry, Mr. Johnson, your hand is raised. I'm sorry, did you have
Well, yeah, I was going to say, so I'm glad that you brought that up, Dr. Faulkner, because so for people who generally are uninsured or can't afford it, I don't know about the companies that actually manufacture the drugs that you're talking about specifically, but I do know that for expensive drugs, many companies have patient assistance programs that can actually reduce the cost of the drug to, either very, very little in terms of a copay or $0. And that's to ensure that a person gets that drug. So I don't know if that's going to happen moving forward.
However, If you have Medicare, Medicaid,
then it won't happen.
then the patient assistance programs are not available to you.
Yeah, it won't happen. Now, hopefully what will happen, especially in the term, like with Medicaid, it's a little bit easier to get a drug like that covered because you can do it through the formulary adoption process. And what ends up happening is that the medical director for that particular health plan would go to the drug manufacturer and say, hey, we need to go ahead and cover this. Or the person from the drug manufacturer would go to the health plan and say, hey, we'd like for you to go ahead and cover this because we are taking care of X amount of your patients that have this drug, and it's more cost effective to go ahead and do that. The other way that it could get covered through Medicare, again, depending upon the amount that it is, because if a person is impoverished and on Medicare, then it's a little bit easier because then they become eligible for what's called the low income subsidy program. And so what the LIS does is it will eliminate all of that stuff that where you go from your initial deductible through the donut hole, your catastrophic phase, where you get to the end. And these are all Part D things that I'm talking about, people, in terms of how drugs are paid for by a Medicare Part D plan. If they have the LIS, then once they run that test claim for that drug, generally it's always going to be that amount. I think it's like $9 or something now per dose. But the other part too is like, this is healthcare, and this is just Shane talking now. Shane talking, not Shane talking for anybody else. Until we decide that healthcare in this country is a right and not something that we can commodify or make a profit off of, we are always going to be having these discussions. I personally think that healthcare is a right. It should not be commodified, and we should be able to give it to everybody. But again, that's just Shane.
I think that that is a good place to move forward. But I have to reiterate my thanks to each of our speakers for their really insightful perspectives. And I think that we've had a lot of questions from the floor. I see that there's still a lot of people in the room. If you would like to come off mic and, you know, just kind of share some of your perspectives or ask a question or even give feedback. I'm seeing a lot of feedback in the chat. Very grateful for that. But I'm giving you the opportunity. We're all still here. If you have something that you'd like to raise with one of our speakers, please feel free to do so. You can come off mic and do so. Don't be shy. Okay.
Well,
it looks like
I'll say one thing. It's not a first of all, thank you to everybody for all the great information. I am a financial advisor, and some of the information that I was listening to about the financial aspects was very informative. Sometimes my clients, they may not have the particular needs, but they may have family members that do. And so I would just like to be able to get all the speakers' information because I'd like to maybe stay in touch with them. So very informative though, so thank you.
Thank you, Ms. Holmes, for your comments. Well, we will absolutely send out their contact information. As we do these every other week, we do send out follow-up information via email, and we will include their contact information. Absolutely. It looks like Dr. Faulkner has placed the covid.gov webpage in there for people to self-educate on how to avoid some of these costs, because I don't know about you, I certainly know that I cannot afford to fall victim to this. I'm just going to move on a little bit. We've done our thank yous, but I do want to ask the group, since you seem to be thinkers and we're speaking very critically here, I want to bring up a question about what we as an educational institution, what our role could be in terms of raising up issues to our legislators or doing more innovative research that is more community facing, not that we are not already doing that. But this is the time that if you have any thoughts about what else Howard University could be doing, this is, like I said, part of a series where we try to take the data that is being generated by our scholars and presenting it in a way that we hope is relevant and can just help people make some decisions about their daily lives. So if there's anything that you think that we could be doing differently or better, please let us know in the chat. And with that, I'd say that we've well gone over our time, but I think that people are appreciative of the information that we've been sharing. I know that I've learned just a lot. I'm sorry, that looked like there's something coming up in the chat. Oh yes, our email address has been placed in the chat, so that's how you can get in touch with us. As you leave this evening, we thank you again for your time. Our next call is going to be on the 9th of June, and we're going to have another very stimulating conversation. This one is about basically how we can remain safe this summer. As came up in the chat just now, people are moving around as if this public health emergency is over with, and we know that that is actually, the truth is actually the opposite. So we're going to have one of our Howard physicians, Dr. Okoye, speak plainly and specifically about how we can make better choices and still enjoy ourselves this summer, because the things that are happening outside already, people are partaking and they're getting sick. So we want to see how we can strike a balance, and there is a balance that can be struck. So that said, I'm going to wrap up our call for this evening. Thank you so much to all of our participants, our speakers, Dr. Henke, very informative, never saw that coming. Ms. Brawley, Mr. Johnson, and Dr. Faulkner, thank you so much. And
Thank you.
as you close out this evening, you will see a very short survey pop up on your screen. Please be sure to give us your thoughts and your perspectives, and we will see you in 2 weeks. Have a lovely evening. Be safe. Take care of one another.
Thank you. Thanks for having us.
Thank you for having us.
Thank you.
Bye-bye now.
Thank you. Goodbye.
Thank you.